So please welcome Mr. Derek. And also I'm inviting Mr. Peter Benjamin. He's already here. Welcome, Mr. Peter Benjamin, who is also working for, he's the Executive Director of Health Enabled. And then we have Mr. Andrew. Mr. Andrew is coming, as well as Shupo. He says he's graduated from being Mr. So Shupo, welcome. Shupo is the Director of Africa Alliance of Digital Health Networks. So distinguished guests, I would like to welcome the panelists here at this session. And we are going quickly to have Mr. Derek talk about what are we doing at the WHO level in terms of strategies, in terms of implementation within and across countries. Mr. Derek.
Thank you very much, Madam Moderator, and thank you very much for taking time to actually, spend time with us around the topic of digital health. And we're pleased that WHO to actually share some of our experiences. And one of the things I need to maybe state is that the regional office in Africa supports 47 countries in the region, and they vary in terms of languages. We have a number of English-speaking countries, French-speaking countries, and also Portuguese. So in responding to the question, I actually have a presentation to just, sort of like walk through the state of digital health in the region. It's a tale of 3 phases. As most of you may know, in 2005, WHO, at the World Health Assembly level, enacted the idea of having digital health into ministries of health. This sort of like stimulated the, implementation of digital health in many countries. Now, what we have seen since 2005 is a rapid progress in terms of implementation of digital health. Now, in terms of telling the story, I have 4 items that I'll actually speak to: the progress made, summary of key issues, and some of the roadmap interventions, and also I'll speak lastly about some of focus areas and the next steps. So speaking with the progress or the state of digital health now, in the next slide, you see a visual display of the progress that has been made since 2005 up to about 2017 or so. Next slide, please. So the map that you see represents about 23 countries that have since developed a digital health strategy. It's critical to remember that digital health exists within the health sector, and because the health sector has instruments to guide the implementation of health, a number of countries have been able to develop a digital health strategy to govern the implementation of digital health. And in as far as, next slide please, and in as far as the solutions themselves, like I mentioned, since 2005, that particular year is quite critical, because since then to now, there's been a rapid progress in terms of solutions. There are key examples that we can talk about, especially mobile examples that many countries have been able to implement in terms of, improving service delivery. However, this rapid growth in terms of, implementation of solutions based on the strategies has introduced a particular problem, which is highlighted in the next slide. And the problem that we are really speaking to, next slide, please. The problem that we're speaking to is that, so digital health as an idea is well understood. Everybody knows you need solutions into the ecosystem. But the key issue that we now face is the issue of verticalization, multiple systems that don't talk to each other, which is the issue that we're addressing at the moment. So in 2005, there were very few systems. In fact, digital health was almost a strange phenomenon in the health sector. In my experience, I've had to deal with nurses that were really afraid, to use a mouse, for example. They would sweat in terms of trying to use that device. But now people understand that. The problem now we face is multiple solutions that don't talk to each other. So based upon this, we have created a cooperation agreement with the International Telecommunications Union to now address the current challenge. How do we now harness existing efforts, and how do we put this together in such a way that there is interoperability, the health workers are able to use digital health without fear, and etc. So this arrangement, which is the next phase of the roadmap of digital health, it sits on 4 pillars. One being, how do we enable existing efforts to talk to each other so that the ecosystem is integrated? Secondly, how do we ensure that the health workers themselves see digital health as a natural instrument in the provision of care? Then thirdly, how do we now build intersectoral capacity at country level between ministries of ICT, ministries of health, and ministries of civil registration? And lastly, how do we make use of medical devices that have an e-health orientation? In the next slide, therefore, the summary basically in the next slide is the whole intention of this next phase, which is really getting countries to scale and reduce pilotitis and ensure that digital health is showing results and improving health outcomes. This arrangement is intended to address that question. How do we harness existing efforts? How do we move from pilots to scale? And how do we ensure that digital health is well integrated? Next slide, please. So again, it needs to be recalled that digital health does not exist in isolation. It's a means to an end. And so based upon this particular cooperation agreement, the whole idea is to ensure that we have enough capacity at country level. Next slide, please. I have a few more slides to address that question. Next slide, please. All right, what you see in that pillar is the context into which these pillars fall. So our 4 pillars exist to support applications, which is the foundation. And the 4 pillars exist to ensure that universal health coverage, which is health for all, is actually attained. Next slide. Again, as been mentioned, the actual program is an end-to-end implementation. So you have multiple applications that are being implemented, multiple stakeholders, multiple users. This intervention is intended to have an end-to-end kind of an implementation covering all the various elements of the ecosystem around the digital health environment. I'd like to conclude with the next slide and simply state, if we may go to the next slide, please. Next slide. I'd like to conclude that one of the emphasis in this program is to improve the capacity, not only to provide care, but to ensure that that particular care is generating data for decision making, and that that data itself is translated into policy. So this roadmap includes really putting all the various players in the ecosystem in such a way that they're integrated. It also is a means to accelerate universal health coverage. As you know, most users now use mobile phones a lot. And so just like we have a goal of universal health coverage, the data side is intended to ensure that we're monitoring how we're achieving the universal health coverage. So we say, leave no one behind. Generally, as WHO, in digital health, we say, leave no one offline. Thank you.
Thank you, Derek. I think it deserves more than that. I think he just explains where we are coming from, where we are going, and also the application of digital health to our decision as a policymaker to change the health and the life of the people we are serving. So quickly, Andrew, can you let us know where, if we want to apply this into ICT platform, where we are, what is the roadmap, and what are the challenges to change the life of the people using ICT? Andrew de Bozios.
Thank you very much, and my apologies for walking in a few minutes late. Thank you for coming. ITU, I think she explained who I am. I'm the ITU Regional Director for Africa, and my responsibilities include implementing the ITU mission, what we do. What do we do? Among the 3 bureaus, which are standardization, creating standards for everything that is ICT and telecom, including management of radio communications, including keeping your satellites in the sky in their orbits, registering them, including making sure that you have regulation in everything ICT, not just telephones, but also in how such applications are applied. You need to protect them. They need to be protected by law and by regulation. We also do development. Development is the support of member states in developing their ICT and telecom sector, and in partnering with sister organizations and private sector and academia in implementing what should be implemented in this sector. The membership of ITU is unique. It's probably the only UN organization that has member states. We have 193 of them. That has academia. We have over 700 members. That has private sector, over 700 members. We have academia. And what that means is that we have a lot of resources to draw on. So zeroing in on digital health, we've been at this for some time. We've been working with WHO for some time. We've implemented together, developed strategic plans for e-health. We've implemented mobile health applications, and I can cite diabetes, which is now becoming really, really a lifesaver. We have implemented cervical cancer for the prevention and, should it happen, management of those diseases. We've dealt with cardiovascular diseases, again, in prevention and in management after the fact. And now we have deliberately created a partnership with WHO in order to together look at the longer term holistic picture. What is required in Africa to have a digital health ecosystem, really? And he's been through a lot of it. I knew I shouldn't have spoken after you, but I did nonetheless. But in looking at this, in looking at the pillars that must happen, first of all, it's not a one-man or one organization job. So we need to build alliances and assign expertise where there is expertise. Number two, we need to raise awareness, because the people in whose hands you put these tools and these frameworks must be able to discern in their minds the importance of use of these tools. And therefore, starting with digital health leaders and the capacity building in that realm is very important. And we are very good at doing that. We are very good at breaking technology down to a level that non-technology people can understand, non-technology people can take and own. Secondly, it is to build an environment where existing tools can be used, new ones can be developed, and build a platform that is common to everybody. We know that there are hundreds and hundreds of applications that different institutions use, and yet in a situation, a life and death situation like that, you can't be running down from one to the other. And so we've taken the responsibility to, together with WHO, to build a platform that will draw these different systems together. So the person that needs them can sit on this platform, be able to use them. Use them for data collection, use them for analytics, use them for management of clinical situations, use them for research even, getting research data. We then, another thing where our expertise would come in is in rallying partnerships in the ICT sector for the health sector. We've done that in different things. I came here right from the south of Ethiopia, where I had gone with the director of UNHCR to see the situation in a refugee camp and how we can apply. But in this case, we are, and I recognize a number of you in the audience, we look to work together with you in creating these partnerships, these synergies that will range from the governments we are working for and their people to the regulators that have to have regulations in place to support the policy, or move on to the private sector to work with operators whose infrastructure we need to use, or build new infrastructure if need be, and then to the health workers and and other players in this sector. So if I were to say in short, what is our role in this partnership? It is to provide the technological expertise and support to WHO, which in turn, whose responsibility then is to the member states to provide these health systems. I think there are new technologies that we can bring on board. We now have big data as just a trending word, but all that data about the personal health history, the data about on research, the data you can analyze in order to prevent epidemics, all that needs to come together. All that needs to be manageable. And we are now looking at demystifying the word artificial intelligence. What is it really? It's something that will help you do a better job and a quicker job at the analytics that you are putting together, and help you to apply those things. Another thing that is important that we come on board with is the matter of data security, because you do not want your health data, your personal data out there. And that is our expertise that we shall bring on board. And let me leave it there.
Thank you so much. Andrew, I think we see where we are coming from verticalization to horizontalization now, the role of ICT into health. I'm turning now to Peter Benjamin. Peter, you are the director of Enabled, Health Enabled. The question that I have to you, how do we see sustainability, and how do you see scalability from the platform that's already created by colleagues? So tell us quickly what we need to know for scaling up and for making sure that we are applying the ICT part of it.
Thank you very much. I'm very glad to be part of this august occasion here. This is the most formal I get. I don't like ties, so this is this is what I look like when I'm drying. I'm with a non-profit organization called Health Enabled. We see ourselves as digital health architects, supporting governments and others in policy and large-scale implementations based in Cape Town. The main thing that I'm been asked to speak around are the steps towards scale and sustainability. Whereas 5 years ago, there were many hundreds of smaller projects, pilotitis as it's been called, there are now starting to be numerous governments and country levels and even regional levels, we've heard some of the global, that are starting to work out how to do this. There are a number of frameworks for this. If you don't know about the Broadband Commission, go and read it, or ask Florence here. If you don't know about the principles of digital development, please Google it, or I can give you the link. There's starting to be very good evidence around that. So just a few points to jump in on. Experience sharing is key at regional levels. We don't have to keep reinventing the same points. We've heard about the excellent work around policy roadmaps and frameworks that the ITU and the WHO are leading us on. And this is, can you still hear me? I hope. And this is crucial for getting the environment that all the projects will work. The professional growth, I think we're going to be hearing about that sometime later, particularly the networks, the education, to build the career, so that there is enough capacity in Africa to not require always external experts coming in, but build the capacity inside the country, inside the continent. On international level, everything starts with political commitment, with leadership from the ministers or others, particularly health, ICT or communications, and in a few countries now even the presidency has been driving digital health. Regulations and policy, if you don't get that right, nothing else connects. You end up with dozens of small projects and all the issues of interoperability and the projects falling apart. Probably the main shift is don't think of these things as digital health projects. This is just a new way that the health system works at scale. If you're trying to do large-scale public health throughout Africa and the developing world, actually globally, digital has to be part of it. In the way that transporting physical things by roads, cars, vans just isn't an issue. We know we have to transport people, commodities throughout the health system. Information and communications is vital, and there's no part of health that doesn't use information and communications. So seeing it not as a separate digital health project, but how can these tools support the whole range of what we're doing to lead to universal health coverage? Again, we can talk a lot around moving from donor projects, which most of the projects were in Africa even a few years ago, to large-scale business models. In some cases, this is obvious. It's doing things more cheaply than they're currently, so it saves money, particularly around data collection and some of the management systems, supply chain that are working at scale, C-Stock and others in Malawi. In Rwanda, where we are here, two stunning examples. If you've not heard of Zipline, that's the drone carrying blood supplies, which is a sustainable business model that's working here in Rwanda. If you haven't heard of Babylon, go and Google it. It's just over a year, it's got 2 million people registered and receiving health support in this country. That's extraordinary, so quickly. And again, business model linked with health insurance. In a number of countries, pharmaceutical secure checking systems that, again, there's a business model. It allows the pharmaceutical companies to verify that it's real, not fake drugs, and that's in everyone's interest. In South Africa, Mum Connect, over 2 million women subscribe to this pregnancy and maternity messaging service. And we're, at that scale, starting to work out how to move from donor funding. Personal connected health is the issue I'm most focused on. Most of what actually impacts on people's health, mortality, morbidity, longevity, actually isn't inside the health system. It's around what else goes on in people's lives. Social determinants of health, community support, being whether enabled to take care of their own health. Everyone wants to be healthy. Everyone wants to support the health of their families and wider. So can't we use these tools to link people to care, to each other? And for example, that goes outside what is often considered usual health subjects. Gender violence is a health issue. And there are huge ways that these tools can be used to reduce gender violence. There's a whole range of other issues around nutrition and others we can talk about. And the last of these, privacy and security, can be talked about a lot. We, in Africa, aren't getting this fully right yet. We're collecting huge amounts of data. In many countries, that's not fully protected privacy security. In many people are saying access to personal health information is actually more valuable than access to your bank account details over the next 50 years. And there's a whole set of issues. For example, Facebook in the last month, how that can be hacked and data stolen. That hasn't happened yet in the health sector in Africa, but it could do if we don't get it right. Just closing, the other thing I'd just like to tell people about that we're involved in Health Enabled is building what we're calling the Global Digital Health Index, a country-level survey and indicators of the level of the environment, the projects, the policy, the range of issues to support sustainability and scale in the different countries. It comes out as a map of the different countries that you can click on and get the whole set of indicators. That's the first prototype of Mali, and we're we're using the range of different indicators that we've learned from the WHO and the ITU's e-health strategy framework. Also working complementary to the WHO's Digital Health Atlas. If people don't know that, that's a mapping of digital health projects around the world that the WHO is leading. And this digital health index is around the country level indicators so that we can share experience, learn from each other, and build the sustainability and scale we all are aiming for. There are currently 13 countries data in. We're looking, by the launch, we'll have 25, a soft launch at the World Health Assembly later this month, then the main launch at the UN General Assembly in September. Can I ask by a show of hands, who here is from a national department? In your country, National Department of Health or National Department of ICT, Comms or others? Oh, actually, not that many. We are looking to work with as many governments to support them to share their data in this way. And if there are any that you're working with, would be delighted to hear from you. So with that, thank you very much for the time. Thank you for the opportunity, Janine. Thank you.
Thank you so much, Peter Benjamin. I would like now to turn to Mr. Schuper, no, Schuper, as the Director of Africa Alliance of Digital Health Networks. So, Shupo, can you tell us quickly how can we foster these opportunities that South to South should benefit from or should learn from each other, and how the collaboration between South to South countries can boost the use of digital health to change the life of the population they're serving? Shupo.
Thank you very much, Janine. I'd like to say good afternoon to everybody. Thank you for the opportunity to speak to you. And having said that and being nice, I'm going to say something not very nice. Digital health, or all the technology in the world, is not really going to help us impact in any way or help us achieve universal health coverage. And that's the fact. As long as we do not diffuse knowledge, diffuse capacity, and diffuse new ideas. It doesn't matter how good or how wonderful something is. It will not make any impact if you keep it in your room, keep it in your drawer, or keep it in your wardrobe. You're going to have to share. We are going to have to share a lot of the knowledge we have. If you look at the global South-South, there's a vast amount of knowledge domicile. If you look at this continent, it's 53 countries. I have had, by the grace of God, the opportunity to interact and work in a fair bit of those countries. And I can assure you there's an immense amount of knowledge, capacity, experience, and learnings in those countries. If we are going to be able to leverage the power of digital technologies in health, one of the first things we're going to have to do is to get very quickly on board with the idea of South-South cooperation in its true sense. There's a lot of stuff that's happening in Rwanda that is relevant and useful in Ghana, in Nigeria, in Malawi, in Tunisia. There's all kinds of stuff that's been done in South Africa that, if replicated or if the knowledge was appropriately shared, would change the lives of people in Senegal. At some point or the other, we're going to have to stop talking about the South-South cooperation and just start doing. And it's so easy to do. If you look around this room, a number of you know somebody else who's in this room, or a number of you have met somebody else who's in this room for the first time at this conference. So it means at least each of you has walked up to a new person and said, "Hi, my name is XYZ, this is what I do." You have interacted. You have exchanged your complimentary cards. You have done that one thing Africans are phenomenally known across the world to do. You have interacted. You have shared your experiences. You have shared yourselves. Ladies and gentlemen, until we bring that complete component of our Africanness into our knowledge space, particularly around digital health, all the wonderful things Zipline is doing here in Rwanda would help the Rwandans, but it will not help their neighbors. It wouldn't help the folks in West Africa, And sooner or later, no matter how wonderful your health system in Rwanda gets, you would have neighbors who would come into your country to leverage your health system and create a burden for it. So think about this. If I live on the first floor and you live on the second floor, as long as you do nothing when my apartment goes on fire, it's a matter of time. It's a matter of time. Your apartment is going to go on fire too. So sooner or later, we're going to have to take the attitude of we must collectively as a corporate entity made up of several individual bits, we must collectively start to work to help each other solve problems. There's so much stuff that's been done in one place that can be replicated at a fraction of the cost. So because the first man spent $2 million to achieve something, the next man does not need to spend $2 million for possibly an introduction of a fraction of that cost. You can improve on what has been done, leverage it, and utilize it. I look around the room and I see a number of people who I had known very well by email before we actually met. There's Richard Gakubas sitting there. Noella is in the back. Up until an hour ago, I thought Noella was a figment of my imagination because I'd been sending her email, we've been exchanging emails, but we hadn't spoken. I've talked with Noella. I have engaged with Richard over the years. There's Derek there, there's Hani, there's Haitham. These are people I have engaged with over the years, and I have learned from them. I have taken information and knowledge from them and utilized in my space. I would like to believe that by the grace of God, I have shared some of what I have known with them. So ladies and gentlemen, if digital health is really going to have any impact, if the whole of the digital technologies implementation in health would not be a nice have and a lot of money spent, we're going to have to start sharing. The WHO and the ITU have come up with this awesome initiative to push the use of digital technologies in health. But that initiative is only as useful as how we leverage it. If you have a very, very good car parked in your garage and you never drive it and you continually walk all over Rwanda, you're not going to blame anybody when your shoes wear out. You cannot blame anybody when you're tired at the end of every day. So you need to leverage that tool. You need to use that institution. There are several other institutions that have come together around the world that are focused on that coordinating collaboration. When we start doing that, then we would stop really talking about South-South collaboration or cooperation. We will just be doing it. How many people here actually have a formal process of engaging with the younger brother, younger sister, cousin, auntie? Nobody. You just engage. In closing, ladies and gentlemen, I would say, before you leave this room, make this one commitment. Meet somebody you have never met before. Exchange contact details with that person, and within a month, learn something new or share something new. You may not realize it, but that new bit of stuff you learn, you may use somewhere else, trade off with somebody else. You may end up saving somebody's life. Thank you very much for your time.
Thank you so much, Shupo. I think you just said clearly, simply, and we get it clear. So now, back to us, audience. Do we have question, clarification? We have 2 minutes each to ask question to our panelists here. And please introduce yourself and go straight to the question. So the floor is yours. I'm sure Richard has a question.
Good afternoon. Thank you for a wonderful panel so far. I have one question. I saw one slide, Derek, that you showed the percentages of, mHealth and eHealth records in Africa. Is there a place today that really does map, wonderful, by the way, the map also for the National Digital Health Strategies. Is there a place where you can really backtrack to see more details on that one slide where you had 28%, mHealth projects, et cetera? Do we have a mapping of that so we can start getting a real idea of where we truly stand? Or is that something that we could work on? Thank you.
C'est Monsieur Yves Calomé de la RDC. Mon problème concerne la mobilisation des ressources pour l'infrastructure. C'est-à-dire que nous pouvons avoir des logiciels intéressants, mais quand au niveau de toute la République, il n'y a pas suffisamment d'accès à la connexion Internet, on ne sait pas synchroniser et faire monter ces données. Alors c'est vrai que c'est la responsabilité des gouvernements et autres, mais l'état des faits sont là. Donc aujourd'hui, les solutions que nous avons réussi à implémenter pour le ministère de la Santé en République démocratique du Congo sont des solutions VSAT qui nécessitent énormément d'argent en termes d'implantation et de maintenance. Alors est-ce qu'il y a des mécanismes ici et là où nous sommes pour mobiliser les ressources dans ce sens en dehors du gouvernement? C'est ça ma préoccupation.
Yeah, Kizito?
My name is Kizito Kayumba. My question addresses mainly to Andrew and Derek, maybe. I have heard that you develop very good software that can be useful and which can be interoperable. What are the mechanisms for rolling out and making sure that every country is implementing the same software to avoid duplication?
Thank you. My name is Sylvie Insanga. I work at Rwanda Information Society Authority. I'm in charge of digitizing the social cluster, including the health sector. I'm sorry I was not here. I don't know if they really addressed my question, but I want to throw back to you the question I'm asked every time, if it's really worth investing the amount of money in health. When you are seeing people dying and you see the price of digital health services, it's really huge at the point people ask themselves if it's really worth it. Yeah, I try to explain, but I would really love to hear more from you. Thank you.
We can take one more question.
Yeah, sorry, I stole the microphone. No, so my name is Kenneth. I'm working for a company called Viamo, stands for Via Mobile. And it sounds like what ITU is doing is what we already have. So we already have a health or a mobile platform, and it can cover any topic in the world. We're in 25 countries, private sector, and so on. So my question to you is more in terms of if you're building a platform that is going to be rolled out, let's say by the World Health Organization, is it going to be open so that it can also communicate with other systems, for example, through APIs? Thank you.
Thank you so much for your question. So, I'll come back to now Derek to pick up two questions, I think, that were addressed to you, and then we can move on with the panelists.
Thank you very much for the very useful and very clear questions, which are actually very practical. And beginning with the question that Florence raised, which actually should be taken seriously, because lack of visibility of implementations is a catalyst for duplication. And again, this is actually to speak to the elements I had in my presentation. When digital health was being implemented, an implementing partner would arrive, unaware of what else is happening in the country, speak to the ministry, who are usually more inclined to say yes to suggestions, and then all of a sudden you have a system in that corner of the country. 2 months, somebody else comes, and you have a system over here. So the question of visibility, and also specifically speaking, inventory of digital health systems is a very important one, which is what Florence is speaking about. The statistics I actually showed in my presentation, which are drawn from our routine survey on digital health. So every 3 years, we conduct an assessment of the progress of digital health. We use that to actually, assess the penetration of digital health in countries. However, that survey is a survey. It does not address routine requirements that ministries need. So therefore, it's very critical to build capacity for ministries to be able to inventory activities that are being done in the country, showing where the intervention is being done, for what purpose, and etc. So as WHO, we've partnered with PATH and developed a digital health atlas, similar to what Peter was talking about. The atlas is a useful tool, and that's the place, the natural place that would invite all implementing partners, governments, to invest in terms of populating the digital health investments that are taking place at country level. And so one of the key steps, especially in the cooperation agreement we have with ITU, is to really require countries, if they have not yet done so, to conduct a thorough inventory of what's happening, where, by who, and for what purpose, into this database, which is really available for registered users. That is a location, and I think I really need to emphasize that we do well to ensure that we're not duplicating efforts, but building upon what actually has been done before. So the Atlas is actually remarkable too, and it sort of like takes us forward in the management and governance of digital health activities. So that's really a very important question for us, and thank you for bringing that up. Next thing I really want to speak about is the question of interoperability, sir, that you talked about. It's an interesting one, and I just need to mention that for a long time now, we sort of like have used big terms in the digital health space, and so nobody understands what we really are talking about. And so interoperability has been a term that we've used for a long time. The time has come that we should actually address that in practical terms, in terms of implementation. As I mentioned, we speak about interoperability, but there are very few examples. Many countries today have enterprise architectures that will diagram what they're intending to do in terms of interoperability. So one of the first pillar of the ITU-WHO agreement is to support countries to actually take the next step of ensuring that they have an interoperability framework that ensures that systems in the country are actually talking to each other. So we are more inclined to support open systems, definitely. So as WHO, we usually don't prescribe, but open systems are more sustainable for most of the countries in our region. And there is a process. Interoperability attainment is non-trivial, okay? And that's why very few countries have attained it. So we've designed a process which sort of like takes, it's a step-by-step process. It's actually a publication that ITU will be releasing. It's sort of like is a guide of what is your first step and your second step towards your interoperability roadmap. And again, time has come, as I showed in my presentation, to address this issue. We need to bite the bullet and ensure that all the investments that have taken place in isolation of each other have a natural home, which is in this case the interoperability framework, for them to actually speak to each other. So that is one of the pillars, and we're really hoping that we can address this. We have planned a capacity building workshop for 20 countries in July and in August, whereby one of the key topics we'll be addressing there is how do you attain this kind of a framework. And so this is sort of like is our first concrete activity in the collaboration agreement. And we're really hoping that we can work with all the partners present to really, in practical terms, show what interoperability actually means, so that the health worker, who usually is intimidated when we say interoperability, actually can experience the life of living in an interoperability environment. So those are the two responses. Maybe I'll leave the other two, but if need be, I can actually address the other two. But let me leave, I know Mr. Rugege is very keen to address a few points, so I'll leave some of the questions to him.
The difficult ones that you didn't answer. Let me attempt to address DRC. I think, and we just had in the opening of the Transform Africa conference, we have a lot of money in Africa. We really don't need to go around with a plane. But we are not using that money in the right ways. And why are we not doing that? Why are our countries not doing that? I think it is a matter of understanding, a matter of prioritization, really general awareness. Because you can't tell me that something that affects the health of citizens is the one that comes at the bottom of the millions of dollars in the government budget. But if you explain, and I would like to link this to Sylvie, if you paint the picture, build the capacity of people to see what the relevance of, first of all, collecting data, what that data is used for, the accuracy of your diagnosis, the history that would then help you to address the next of kin or down the line in the family, you would then start to show this person that you are actually saving money going forward. Because if you have a hereditary disease that is not known to be a hereditary disease, your grandson is going to have it. So countries at a state level, at a policy level, need to realize that with technology, we can do what we currently can't do, what the human eye can't see, we can now see with robots. So we need to change the mindset of how we think about digital health, how we think about health actually, right, in terms of prioritizing. And where Sylvie asked whether this is really worth it, maybe if you look at 1 year time frame, maybe it's not worth it, because if you spend $1 billion in upgrading your system, in educating your people, you end up not taking people from Kinshasa to go to Brussels for treatment, because you will have proper diagnosis, treatment, management on the ground, or even if you don't, you will then have a adequate remote participation of a consultant doctor. In terms of the platform that we are talking about, I actually want to add a word onto interoperability. I want to add conformance. We've been plagued by ourselves going out and accepting to buy a piece of technology, a piece of equipment that works with nothing else. It arrives in the country, right? And you either have to buy the same equipment for the rest of your ecosystem, or you have to throw it away. So it is very important that we start to look at whether our acquisitions in terms of technology conform to certain standards so that they meet the rest of what you have, right? So that they may be interoperable, and then you don't have to buy anything. The platform that we are talking about building, that we are designing, is a platform that will enable you to not only collect data, perform analytics, but also draw from existing platforms, from existing applications that you have. Because those are in place, those cost a lot of money. We don't want to just throw them away before their time. And so it is very important to be able to have on one dashboard, right, data drawn from even the systems that you have not. I think if the chair allows, my expert over here would like to add something.
Okay, no, just to respond, because I think you raised about this platform thing. Just to clarify, we are not building a platform. We are making sure that countries will have a platform out of existing commercial or open source software. We are not building a new software, because we don't see our role as building software, because I think there are already a lot of good software out there, including Viamo, who used to be Voto Mobile. Yeah. Well, it doesn't do everything, because I used it, okay? So it's very partial, only for voice. Even SMS is very limited. But anyway, I think it's a great model, and there are a lot of good models as well on the ground. So the idea is that we work with governments to identify the requirements, to put the framework, so governments can put in place a common platform out of existing software that can be reused for everyone. So just this clarification, because I think your question was very important. Thank you.
Thank you, Janine. I actually wanted to talk to the gentleman who was talking about resources. And yes, indeed, whether it's satellite connectivity, 3G mobile, or even handsets or tablets or computers, these things cost money. And that is just the practical reality of life. They cost money, and they will continue to cost money. And I'm going to circle back to something I had mentioned earlier. We need to look at our digital health implementation. Like all implementation, a bit more holistically. We need to take a bit of a system approach and stop looking at it programmatically. So something may work for the malaria program because there's a donor funding it, but you find that it's not scalable to the entirety of your health system. And that goes back to a core objective of the African Alliance, which we'll talk about later, but it's capacity. It's not just capacity to implement, capacity to manage. First and foremost, capacity to plan, capacity to strategize, capacity to forecast, capacity to decide. If we go down this road, 6 months down the line, is it sustainable? And I'm not just talking about financial sustainability. If we go down this particular road with this technology, is the technology fit for purpose? What may work when you're looking at 40 facilities in a pilot may not work when you want to scale up to 100 facilities. And that is the kind of capacity we need to build and share across the continent. So before you start your implementations, you come up with a plan. A number of African countries have come up with a digital health strategy. They're evolving that. From that strategy, they're building out plans, and they're costing those plans, which means there's an investment first and foremost before we start doing stuff. Let's think it through. If a lot of that is done, you may find that the resources you require for your digital health implementations are not necessarily money. I am going to say something that may shock a lot of technology people. I've been a techie all my life. But sometimes, in some circumstances, the best and most appropriate way to utilize technology, particularly in health, is not to utilize technology. But we need the capacity to make those decisions. Is this fit for purpose? Is this best of breed? Is this sustainable? Like Andrew said, how easy can I use this alongside what exists? When we build that capacity across the continent, it doesn't suddenly mean lots of dollars, kwacha, rand, or pounds will fall from the sky. But it means every dollar, every penny, every naira, every cedi we spend, we will be able to maximize the reach. So we will increase the return on investment. To the lady who was talking about return on investment, we will increase the return on investment for a less investment. This goes back to something else Andrew was talking about. There's not a lot of information about how valuable or worthy digital technology is in health. Because, you know why? We don't do a lot of data collection around those implementations. We don't document our failures to share. We don't sound out, hey, Peter, you guys did this in South Africa. Did that work out? But it's nice, it's good, it's cool. Let's go ahead. So I will say again, let's build capacity, let's share capacity to plan, to strategize, to cost. In essence, I say again, let's be Africans. Share. The little you think you have may be a lot when your neighbor gets a bit of it.
Thank you. If I can follow up on the really valuable question that my sister asked, is it worth the money? And we have to take this seriously. As we know, health is so resource stretched. And my short answer is, I'm not certain we're working it out. There are many projects at the start of this field that have been where money absolutely has been wasted. We did a survey in South Africa, 125 mHealth projects about 3 years ago. About 70% of those don't exist anymore. When the funding ended, it closed, it went down. So, and that, you could say it's money wasted, or if we do it right, it's lessons. Because while the multiple dozens of projects largely going to waste money, what we're working out is that from that, where there's one or a few large national scale systems, exactly what our brothers in the WHO and ITU are saying, that I genuinely believe will bring health value to the majority. An example, again, South Africa, there were 45 different messaging to pregnant women, tiny projects. There's now One Mum Connect of 2 million. The government said, this is it, most of them fell away, and now just one. This is an absolute example of public-private partnerships. We talk about ICT. That's private sector. You don't get the rollout of the mobiles and the infrastructure and the basic infrastructure without the private sector. And this is happening. As we know, already a majority of Africans have got a cell phone. In a decade, it'll be a vast majority. If we're not, a lot of people are working out how to provide some information and certainly how to make money from that. If we're not working out how to improve health from that, we're missing the largest opportunity for improving mass-scale health, universal health coverage. Crucially, we talk about interoperability within health. Let's think wider. Other areas around development. Similar infrastructure and services and data collection are needed for education, for agriculture, for employment. If we just think of health, there's another form of silo, though it's a much bigger silo, it's all of health. And that's, again, the level of e-services, government coordination on this. Definitely we need more health economic studies, so we don't just waste money, that there actually is proven cost effectiveness. But perhaps we could think of it like this. The donor funding can innovate. A lot of the donor funding previously, where the projects didn't continue, it was working out what does and doesn't work. Then the private sector moves in when there's something like a coherent business model to extend what's going on. Many good examples we're saying, though we also should admit that the private sector largely focuses on the wealthier, where it can make money from. Though they're starting, as we're saying, there's some other examples where these can be extended generally to mass services. And then governments should only get involved in in the public sector when we're just about sure that this is a valuable way, that a rand or dollar, franc, kwacha, whatever, spent on digital health, we can defend that it's of equal value, if not more value, than that going on a nurse or extra vaccines. If we can't say that, at least within a few years, we're playing. We're not answering the real questions that you're saying that in such a resource-poor setting, can we justify the money? And I think we can, but we're working out how to do it. And it's at national level systems, exactly what the ITU and WHO is leading us in, that the answer could come. Thank you.
Thank you so much. So, Derek, I have a follow-up question on, we talked about digital health. We are talking about investment. We are talking about infrastructure. And yet, the people who are concerned, community health workers, doctors, health providers, are still afraid. How do you see the role of WHO playing in making sure that the health providers, up to the ministers and the government, are actually using the tools for their own benefit, for the health of their own and also the population?
Thank you so much for that very important question. Very important because systems are nothing if there's no end user utilizing those particular systems. It's a critical question because everything that, everything that concerns digital health, at the end of the day, there's somebody that has to use the mobile phone, use the computer. Usually, preferably, this should be the actual health worker because digital health is a means to an end and not the end itself. So we have recognized the fact that producing an e-health ready workforce is very critical. And this is a second pillar in the ITU-WHO agreement. It's a very important point because most systems have failed to thrive and grow because as far as the health workers are concerned, there is, digital health tools are meant to be used by IT professionals. So as I mentioned previously, the e-systems we talk about were usually used by IT people. There are many solutions that we have seen whereby, you deploy a system and then you bring in an IT personnel in the loop because the health worker is unable to use the medical record system, for example. And that has ethical issues because somewhere the patient has to interact with the medical personnel, and then you have confidentiality issues that actually come to play. In my own experience, actually, I began by developing pharmaceutical systems, and I recall trying to to fix a bug in the pharmacy, and the pharmacist could not allow me, one, to actually be there when the patient was actually present for right reasons because of confidentiality issues. In other settings, you have systems that are used as point-of-care systems, and then you have a situation where the physician is unable to use the medical record system, so they hire an IT person to sit next. Again, you have ethical issues there because as far as the patient is concerned, they're supposed to be interacting with the physician. If you have an IT person doing record keeping in the same room, you have ethical issues there. So these are practical issues. And so therefore, what we have aimed at doing in terms of building an e-health ready workforce across the spectrum, from the policymakers themselves, which are usually these are directors, these are ministers of health, to the actual program managers and the frontline health workers. The pillar on e-health capacity building for the health workforce addresses these three layers. And you'll be surprised that the things we take for granted, the things we really take for granted out there, the average end user is unaware. More often than not at ministries, when I say e-health, I've been asked, so the E stands for what? When you say M-health, the M stands for what? So it's an issue we take for granted because we've all been using digital health tools for most of our lives, but the person you're expecting to use the systems, the community health worker, the medical professional, is unaware, or rather is not capacitated in terms of being able to use the systems. So one of the concrete things we'd like to do, of course, is to, as I mentioned, in this capacity building workshop we'll be having in July and August, which is the first concrete step, is to build a curriculum that addresses the needs of the minister at his level, so that if the e-health program manager is asking for a budget, the minister knows exactly what we're dealing with. It also addresses the technicians, as was mentioned, when you say interoperability. Most of the technicians we have in ministries of health do not have this kind of an experience. So capacity building there is essential. And also the end user, which usually are the health workers. Okay, so we're aiming at building a system to ensure that digital health is integrated within pre and post-service. Okay, so pre-medical training, there has to be some ways to integrate digital health learning so that as you have new cadres of health workers coming out of institutions, they already know what you're actually addressing. But you also can't ignore existing health workers who actually need a different skill set or a different means of education. So at the end of the day, we hope we can build some e-learning platform, platform that, if a person who is already out of medical training and is practicing needs to have some kind of orientation or learning around digital health, they can go to this e-learning environment, take a course, and have it registered with the Director of Planning. That way, ministries are able to say, within our country, we have so many doctors, so many health workers that have this skill set. And also the ministries are able to say, we've planned for the future, as people graduate, we have built capacity around digital health so as to ensure that we're all speaking the common language. So it's a very ambitious idea. It's also an existing gap. As I mentioned, we take things for granted, and that's why systems fail. Systems are usually successful if you have champions. And in this particular case, we are working to ensure that the end users themselves are the champions, and we're providing the technical support to actually provide the solutions. So all of us have mobile phones here. I know that if I pick up the phone, I can make a call. But Mr. Rujeje next here might know the ins and outs. So I don't need to bother about the technologies behind. I'm really focusing on the ability of the phone to do something. So in that same spirit, we'd like to ensure that nurses are seeing digital health tools the same way they used to see paper record systems. The natural way, so a physician knows that I have to chat and I need a pen and a paper. That's very natural. Now the next phase is how do we get end users to actually relate to digital health tools in a natural way that there's no phobia, which actually, again, we should not take for granted, but in a very natural way that they're seeing the tool as a means to an end. I'll be really very happy if we see health nurses complaining that a computer has been taken out of their space because they know the value of that particular instrument. Thank you.
Anybody in my department who does not speak to putting a human face to ICTs doesn't belong there anymore. because we do not build and we do not encourage technicians to build things to protect their space. Even this phone, they call it a cryptic mobile device, something like that, just to make sure that it's them who understand, and you have to come back to them to get that understanding. So we now are beyond that era, and we must start to think about the usability and the impact, the change that the technology is going to make to the life of the people down there, not us on top of the ICT platform.
Yeah, thank you so much, Andrew. I wanted to add on protectionism and licensing. Can you talk about that? Since I think at this moment, everyone now is convinced that I should use digital health for my own health, but also health of the population we're serving. Can you talk about licensing and the protectionism of the developer, and how can we enable that so that we can also respond to the question from my colleague from DRC?
Thank you very much. I earlier referred to the security of data as a major part of what we do. And I think in the news recently, I think everybody knows the name Cambridge Analytica. Unfortunately, Facebook got associated with that name. But what I'm trying to say here is we must take the responsibility that if we are introducing these systems for people to use, we also must make sure that their data is protected. And we can't do that as an international organization, which means we must engage the policymakers and the regulators to put in place a carrot and stick. They must have accountability for people that do not protect the data of users, but they also must be facilitated to get their systems in place. So encourage light touch regulation, right? But also make sure that there are penalties that are paid in order for people to feel secure. In terms of licensing, ICTs are now ubiquitous. So we are encouraging across the board licensing so that the person that has a technology, you license for the use, not the actual technology. We can go into that, but I see you don't have time.
Thank you much. Peter, you talk about the government, the private sector, but also the founder. How do you see the three working together in enhancing the digital health for sustainability? And while I have you, I'd like also, after just to talk to call Shupo for the voices. You talk about the voices as well. The HE today, the President of the Republic of Rwanda talked about the mindset. How can we hear the leaders, the users, the receiver of the digital health, change our mind for a better South-to-South collaboration? Peter.
Thank you very much. The immediate question you asked around the links between government, business, and funders, I think I mentioned something very briefly on that. Funders, donors around innovation, private sector taking that broader where there's a business model, and then governments trying to take to scale those things that can, there is a financial justification for. But if actually you can follow up first what Andrew was saying around the techies trying to protect their domain. Do you know that lovely quote from George Bernard Shaw? All professions are a conspiracy against the public. And a lot of what our job is to get beyond that, to make the systems, picking up the other question earlier, of use to community health workers and other frontline health professionals. To my mind, there's two answers. First, the easy one. As the next generation comes, people are much happier to use the tech, whether nurses, community health workers, or doctors. But I think the real answer, and I've got some experts over there who've been designing these things, is called user-centered design. Don't design systems so the minister or the chief official in the air-conditioned room in the capital city gets the information they want. Design it so it's actually of use and reduces the burden on the health worker that's out there. And to my mind, there are three things you have to get right. First, obviously, make it easy. If it takes a minute to do it on paper and it takes a minute and 5 seconds to do it electronically, they'll hate it. If you design it so it's 55 seconds to do it, less than a minute, they'll love it. Secondly, make it locally useful. So the information isn't only national statistics, but it actually can inform and improve the work, increases the agency of the health worker themselves, rather than just the management. And thirdly, feedback. So as much, the rough rule is as much information goes up, should come down, so people feel empowered by the information and other systems they're doing. And if you get those right, people do know how to use these technologies. Anyone who's got a basic cell phone in Africa knows something like how to send an SMS, how to use voicemail, how to recharge airtime. If you try an USSD or things like that, which often is hard, people with smartphones, many of them know how to use WhatsApp. So all I'm really saying is that if it is seen to have value, people can work out how to use these technologies and design it so it's actually of use to the people, making their lives easier. Then you'll get adoption. Thank you.
Janine, to your question about voices and how we change the mindset, let's quickly think to our relationships. If you have a bunch of friends who generally like to wear jeans trousers, and you don't like to wear jeans trousers, over time, after a while, you would suddenly gravitate to jeans trousers, essentially because when you and your friends go out, you're the only one in chinos, you're the only one in slacks, everybody else is in jeans trousers. And depending on how strong-willed you are, it would take some more time with others than with some other people, but you will generally gravitate. So you do see that basic human engagement opens us up to influence our immediate community or our network of friends, or opens us up to be influenced by that immediate community or that network. If you look around the continent, over the last few years, either at a national or regional level, people have come together around different issues in digital health that are relevant to them. So you would find a bunch of people who essentially are logisticians, who handle pharmaceutical logistics, and who are interested in how technology can help them collect data on supply, demand, request. They gravitate around themselves, they have a discussion, and over time, with the appropriate support thrown in, you get systems that are technology systems that solve that problem. If you put together a bunch of people whose core interest is around education and advocacy, and they work in health, once they begin to think of how can technology help us, they will begin to discuss technology platforms. So essentially, what we need to do is look for a way to strengthen these networks, whether they're local, whether they're regional, whether they're even sub-national. If you strengthen the network, if you begin to coordinate and synergize the conversation, imagine if everybody on this continent who advised the policy advisor in health investment or in technology investment was repeating the same set of buzzwords, the same set of ideas. Let's make sure whatever technology we're investing in health is sustainable. Let's make sure it's fit for purpose. Let's make sure it meets a certain standard. It will take time, but you will build critical mass. And you would have the folks in Rwanda, the folks in Tanzania, the people in Cameroon, the people in Niger Republic, everybody suddenly thinking the same way, because essentially the small units, these small components of human beings who engage with others have decided to think that way. There are a number of digital health networks or gatherings across the continent, and each of them is doing superb things, more often than not, in their small region or within their small space. And essentially, it is to bridge that gap. It is to provide that synergizing, that congruence, that confluence of the ideas, and provide some coordination to how we strengthen the digital health ecosystem across the continent, how we make sure the government, the policymakers, the people who make decisions are all thinking appropriately around digital health, to make sure we're all thinking, do we fit into this larger framework that WHO and ITU are advising? Are we able to engage with the private sector? That essentially, it's to fill that lacuna, that gap. That essentially is what the African Alliance of Digital Health Networks is all about. We're in the exhibition hall. You can't miss our booth. And I would encourage you to engage with us, talk with us. It doesn't matter whether you're a government agency, you're a non-for-profit, or you're an individual. Engage with us, connect with us. Let us look for ways to, first of all, synergize our conversation. We're not going to be able to change people's mindset or be voices if we're separate voices. So when we synergize our conversation, there's strength in that synergy. And that is what the Alliance, the African Alliance of Digital Health Networks, can then take into that ecosystem and use to change our mindsets. Thank you. Having said that, ladies and gentlemen, you would excuse me if I stand. I'm not very used to sitting down for a long time. My name is Olashuko Oyedepo. I work out of Abuja, Nigeria. I'm the director of a new peer learning network that is known as the African Alliance of Digital Health Network. We are essentially an actualization of a vision of a dream that has spread across this continent for a number of years. This is a bunch of technology people, people in health, and people outside of health, whose vision is, let us leverage the power of technology in health to make sure that African countries have, first and foremost, the necessary capacity to engage, to deal, to build, to strategize, to manage, and to take control of their digital health strategies in such a way that it aids where they're going. We are currently receiving a huge bit of support from an innovative project that's called Digital Square. Digital Square is an innovative project that's funded by USAID and the Bill and Melinda Gates Foundation. It sits within PATH. And with their support and the support of a number of superb organizations, I'm talking about organizations like the CRI Foundation, organizations like the Peter J. McGovern Foundation, organizations like the South Family Foundation, like SPIDER. SPIDER is a Swedish program that's pushing digital. Organizations like the World Bank. We are aggressively pushing, we are aggressively changing the mindset. We're working with the WHO and ITU, we're working with Health Enabled and a number of other networks across the continent. And so, ladies and gentlemen, I ask you to join with us. There's an African proverb that says, if you want to go fast, you go alone. If you want to go far, you go together. We definitely want to go far, ladies and gentlemen. We want to go so far we have no idea, we cannot see the destination. And so we ask you, as the time for Africa is now, we ask you around the continent, connect with us. We definitely want to go far. Ladies and gentlemen, we are the African Alliance of Digital Health Networks. Thank you very much for your time.
Because this is Africa.
Thank you so much, Shupo. He insisted that we need to hear that voice. We are Africa. I think a call has come to all of us that we stand up and we use what is available to us to change the lives of people that we are serving. I would like to, ladies and gentlemen, to thank and give a round of applause to our very noble panelists. Ladies and gentlemen, thank you for attending this important session, and we hope to see you soon in the business of digital health. Thank you.